So the first question, I hope if everything is fine, someone put it in the comment box so that it would be easy for us to go through on, right? So the first question is, a 6-year-old child with a history of mouth breathing, malocclusion of teeth and conductive hearing loss. Due to glue ear, which of the following will be the best management plan for this patient? Right? So option A is adenoidectomy, myringotomy, adenoidectomy along with myringotomy, adenoidectomy with grommet insertion. So this is what the first question that was given. I hope you can able to answer over here, right? Can you able to answer? So what is the answer for the first question? So I hope everything is fine. If there is any technical issue, you can let me know by the chat box, by putting a message in the chat box. So yes, so I'll be continuing. So for first question, and the answer is yes, D, adenoidectomy with myringotomy with grommet insertion, right? So why we are going with an option of option D, right? The answer for this reason is, see, in the question they have mentioned, conductive hearing loss, isn't it? They have mentioned a means of conductive hearing loss, where they have done a hearing loss, right? Where there is a means of glue ear and there is mouth breathing, conductive hearing loss is there, and there is a process of glue ear. They have given you a clue. So for glue ear, obviously you have to do myringotomy along with grommet insertion. That is right. But still, in view of adenoidectomy, why we have been going with adenoidectomy? Because of the mouth breathing, as the clue was given that it is 6 years old child, you will be going with an answer of adenoidectomy, because the reason in glue ear, the first, there would be a possibility of adenoid hypertrophy, right? That is also one of the reason in glue ear in children. So if you see it in adult, what would be the possibility? The possibility would be, in adult there is a sign of, yes, a nasopharyngeal, NP carcinoma, nasopharyngeal carcinoma, that is important. Yes, so seeing about serous otitis media, which is none other than called as your glue ear, otitis media with effusion, right? So this is the picture which is showing serous otitis media along with your glue ear in thing. So here, most common cause of hearing loss in children. If we see the most common cause of hearing loss in children, then what would be the answer? That is glue ear. Right? So the next thing, in otoscopic examination of glue ear, what can you find? In otoscopic examination of blue ear, you can see, yes, blue to yellow kind of a tympanic membrane. Blue to yellow kind of a tympanic membrane. Then you will be having retractions of tympanic membrane. Right. The next thing which you see in otoscopic examination is air bubbles within them. So can you able to see this air bubbles? Yes, those are the air bubbles present in your blue ear which you can see in otoscopic examinations. Right. So the next thing would be you will have a shortened handle of malleus. Shortened handle of malleus. So that would be the possible thing which can be able to see. So in investigation in adult it is separate, and investigation in children that is also separate. In adult what we'll do? We'll do a nasopharyngeoscopy. In children we would be doing tympanometry. And what you will get in tympanometry, that is important, you will get a B-flat curve. You will get, that is important. So next treatment would be of meningotomy plus a grommet insertion plus adenoidectomy. As you know, the cause in serous otitis media or glue ear, either there will be a possibility of adenoid hypertrophy, or there would be a possibility of nasopharyngeal carcinoma, that in case of adult. Right. Meningotomy will be done. Where it is done? It is done in the posterior inferior quadrant. And the grommet insertion is done in, yes, that is opposite, that is done your anterior inferior quadrant. Very important question. And the reason why we are inserting that grommet insertion over there, because that acts as your ventilation tube. That is important. Okay. So coming to the adenoidectomy, for it causes mouth breathing, isn't it? The less than 6-year-old or around from 2 to 5 years old of the patient who is in a pediatric age group, they will be suffering from mouth bleeding until and unless they have increase in size of their adenoid. That is why we are doing adenoidectomy along with them, right? So this is what you have to know about the blue ear. The next question, the second question is the most common site of cholesteatoma in middle ear is. What is the options? Option A, epitympanum. Option B, mesotympanum. Option C, hypotympanum. And option D, prosaic space. So what would be the most probable answer for this? Anyone else? Yes. So because of the issue, I cannot get your options. Yes, what is the answer for the second question? Anyone else? So as we are seeing about cholesteatoma, which is the abnormality in middle ear, right? This is a kind of abnormality in your middle ear. The options are 4 options I have been given you. What's the right answer in this? Yes. Anyone? And this goes to an option of D, prosaic space, right? Yes, right, Snehashish. The answer is D, prosaic space. So how it would be the answer? Why there is not a possibility of epitympanum, mesotympanum and all? Because it's a direct question and the direct answer is prosaic space. So no detail about cholesteatoma. We have to see about some parts which is very important in cholesteatoma, right? So seeing about that, in view of this, you have to know some important points about them which is asked repeatedly in your exams. So in cholesteatoma, it is a sac of desquamated keratinized epithelium which happens in your middle ear. And the most common site is your prosaic space. Right? Most common site is your prosaic space of your attic of the middle ear. That is also important. We have 2 things in them. One is your congenital part and another one is your acquired part. So seeing about the congenital part, where they comes from, they are being from embryonic residual cells. In an acquired part, they have been with two things. Either they would be in means of primary or they will be secondary cholesteatoma. So in this cholesteatoma, our scientists have discovered some theories. Retraction pocket theory was there. Retraction pocket theory was there. Yes, right. Mr. Chandrakantan, you're also right that the answer is Prusak space. Retraction pocket theory is there. And the one more name of this retraction pocket theory is, yes, negative pressure theory. Negative pressure theory. That is also important. So the one more important thing is, can you able to see in the picture, can you able to appreciate in the picture a pearly white appearance, right? So this is the normal one and this is the cholesteatoma which gets conversion, right? So this is a pearly white appearance of your collected material in cholesteatoma. The treatment of choice, if we prefer, the treatment would be having MRM, that is modified radical mastoidectomy. That is important. So this theory have another name. They can ask you the name of the theory also, that is Whitmack theory. That is Whitmack theory, important. Okay, so this is what on the whole you have to know in view of cholesteatoma. It is a keratinized desquamation of the epithelium in the middle ear, and the most common site regarding this is your Prusak space. The next question is, so this is a picture which is showing your collection of cholesteatoma particles, means the collection of the keratinized epithelium in your retraction pocket. So please able to, if you can able to appreciate, there is a retraction pocket where your cholesteatoma get collected. This is the right ear which is showing a otoscopic examination. So the next question is, curve in the diagnosis of disruption of ossicles. Option A, option B, AS, option B, AD, and option D, B. So what is the most correct answer in this? And I'm expecting the answers from you. A, AS, AD, and B. So yes, I'm expecting the answers. The curve in the disruption. Yes, the answer is nothing but AD. Why? And if suppose AS, if I have asked you in the question, or if suppose I have asked you B in the question, or if suppose I have asked you A in the question, then what would be the answers? Yes. What if I have been asked, suppose A curve, if suppose I have been asked about AS curve, or if suppose I have been asked about B curve, then what would be the answer? What would be the answer? Yes. If at all I am saying about the A curve, then the curve should be representing the normal middle ear. The curve should be representing the normal middle ear. So if the curve representing the AS, then that would be the diagnosis of otosclerosis. Otosclerosis, and most probably the curve would be in the downward direction. AD, you have said already that there is a disruption of ossicles, right? So then B curve. B is a kind of a flat curve. Just now I said it is seen in your Sinus media, or you can say in your glue ear. In your glue ear. Yes, AS otosclerosis is right. Veer Rathore. Glue ear, and that will be seen in your Sinus media, or else otitis media, effusion we can say. So same like that, you have to know some things about the curve. So this is the type A curve. There is more possibility that they can give you this curve and then they can point out some curved point. So then they can ask you what's the abnormality. You should be supposed to say that too. If suppose in A, if they are being given, A is a normal one which we have seen already. AD which causes the disruption of ear follicles, right? Then there is a B flat curve which is showing Sinus media. The C curve, please concentrate on the C curve where it is. It is in the negative part. So please remember, C curve always shows the negative part in which there is a negative pressure within them, right? So this negative pressure within them shows which type of abnormality? Yes, whenever eustachian tube is blocked. Whenever eustachian tube is blocked, you will have this curve of type C in your tympanometry. This is also an important question which is asked repeatedly in your exams. So please be notifying this, and type C is a means of negative. The rest of the all curve will be coming in your positive side. And B curve shows the flat line. So please remember, whenever they point out the B curve and if they show them, then that would be the possibility of flat, and that represents your glue ear or serous otitis media. So the next question is, the picture in the screen shows option A bat ear, option B tropical ear, option C surface ear, or option D cauliflower ear. And if so, if you are saying the answer, and you have to say me the reason why also. Yes. Yes. So what is the answer over here? And the answer here is D cauliflower ear. So this shows the representation of your ear that is seen in a cauliflower ear. So this is an abnormality or a pathological thing. It happens in your otitis externa. Yes, right. Snehashish and Edak, option D is the right answer, which is the possibility of externa, otitis externa. So the next thing which I am going to explaining you on the whole is what are all the abnormalities on the whole we will be seeing in the external ear functions. So starting with that case, we'll see some important points over there in otitis externa. What you have to remember. See, basically you have a perichondritis where you will be having inflammation in pinna. Inflammation in your pinna or in your perichondrium. So that denotes your perichondritis. P for P, please remember the most common cause for this perichondritis would be Pseudomonas. Important. So apart from this, furunculosis is also a kind of otitis externa. It comes under external ear infection that causes because of Staph aureus infection. So the next condition that happens in your otitis externa is MOE, that is called as malignant otitis externa. And the mnemonic for you here to remember is good night. What is good night? G for G and N. Anyone else? Can anyone say? Yes. And what does it mean? Yes, boxer's ear is also a right answer, which also called as your cauliflower ear. G is nothing but there will be a formation of granulations. In your external ear, and the person will be complaining of a very important unique feature, that there is a nocturnal pain. The night ear pain the person will be complaining of. So this is the two things which will be presented in your malignant otitis externa, and the most common cause for this malignant otitis externa is also the same, Pseudomonas. And here there is one more clue for you which I am giving you is, yes, it will be seen in a patient with diabetes mellitus most commonly. If I am speaking about the investigation, the most common investigation is there, and the investigation of choice is there. Please be very sure about the answer what they are asking for. If they are asking for a most common investigation, then your answer should be CECT. And if they ask you for an investigation of choice, then your answer should be TC99M scintigraphy. So this will be the best scan, and this comes under your gallium scan. This will be the best scan ever. Okay, so this is what happens. And if we see about the treatment as such, we know what is the causative agent, Pseudomonas. So obviously we are going to give anti-pseudomonal agents, and I have said you anti-pseudomonal agents, and I have said you the patient will be a diabetic most probably. So along with that, anti-diabetic medication will also be there. So in anti-pseudomonal you can prefer penicillins, right? So you can prefer cephalosporins, you can prefer, yes, that's a kind of a bone scan, yes. And you can prefer ciprofloxacin also. This is the basic overall view about otitis externa. You have to remember all these things are repeatedly asked. Don't even miss even a single line. All these things are a question. Then If we see about the next question, which membrane separates scala vestibula and scala media? Which is the membrane that is separating scala vestibula and scala media? And the option is A. basilar membrane, B. Reisner's membrane, and C. tectorial membrane, and D. Sharp-Nell's membrane. This is a direct question that I hope that there is no any difficulty for you to answer over this question. So yes, what's the answer for here? Answer for here is, if suppose it is between scala vestibula and it is between your scala media, then the answer should be yes. And here, and the answer is B. Reisner's membrane. So how this, the first part which you see over here, this is nothing but your yes, Reisner's membrane. The upper part you have, right? The upper part, yes, option is B, right answer. V. Rathod and Sandeep Singh. Reisner's membrane is your right answer. So in between scala vestibula and in between your scala media, if there is a part, then that is your Reisner's membrane. Reisner's membrane. If I ask you which is between your scala media and scala tympani, then which is the membrane present over between them? Scala media and scala tympani? Yes, that is your basilar membrane. That is your basilar membrane. Please remember. So here, most probably the question here that is asked is about your organ of Corti and hair cells. Please be sure about that. In organ of Corti, there will be a kind of two cells, right? One is your hair cell. The another one is your supportive cells. So hair cells are responsible for, and we can say in hair cells again there will be a kind of inner cell. Yes, option A, right, V. Rathod. And in hair cell again there is a kind of a outer cell. So in inner cell, inner in the sense there is a kind of a flask like manner. So flask shaped cells will be there in your inner part of the hair cell. If we see in your outer part, there will be tube kind of a cell. That is tubular cells. So if you see, as it is a flask, they were arranged in a single row, and if it is a tubular, they have been arranged in a multiple rows. That is also important. So the main important thing what they can ask you is, in inner cell there is no emission. Very, very important, and this question is repeatedly asked in all of our questions. And in your outer cell, and in your outer part of the cell, there will be autoacoustic emission. Very, very important. Autoacoustic emission. That is important. So in view of another thing, supportive cells, they will be doing a supportive function of your organ of Corti. That is also important thing to be mentioned. So about your balancing function of the ear, morphologically and in the functionative manner, the balancing function of your ear is done by vestibule. What are all the structures which you know in vestibule? What are all the structures which you should know in vestibule? Yes, quickly. What are all the canals which is present in the vestibule? Yes, anyone? That is your lateral semicircular canal, right? Your posterior semicircular canal, and the same like your, yes, your superior semicircular canal. So these are there, and all are having a different other functions, especially in view of semicircular canals. These semicircular canals are having a function of, yes, angular acceleration. Apart from this, all of the morphological and the functional importance is there in vestibule, as they have been involving in angular acceleration. And the linear acceleration is given by, yes, that is given by, yes, right, semicircular canals. Linear acceleration is given by, yes, that is your saccule and your utricle. So that is how they show their importance. Yes, utricle and saccule. Very nice, very nice. So the next question which we are going to see is, syringing the auditory canal for 40 seconds can stimulate. The options are A. posterior semicircular canal, basal promontory, lateral semicircular canal, and superior semicircular canal. What would be the most probable answer for this? Yes. Anyone else? Yes, and the answer over here is nothing but your presence of lateral semicircular canal is here the over answer, because the auditory canal, whenever you're going to syringe them and stimulate them, they will be stimulating the first and foremost part, that is your lateral semicircular canal. But that is, yes, answer C is right, Sandeep Singh. So that is why the reason in vertigo and nystagmus we would do the stimulation of lateral semicircular canal to get that means accurate point whether the lateral semicircular canal are working properly, so that they will be getting stimulation. That is how the importance of lateral semicircular canal. This is a direct question. Answer is lateral semicircular canal. So the next question is most common bacterial organisms causing this condition. What is this condition and what's the most common organism cause? This is a multiple times asked question. Anytime, whatever the repeated question papers, if you see, you can able to see this question again and again. I haven't given you what is this condition, but simply I have given you a picture which is showing this condition. Yes. What is the answer? Anyone else? Option A, Staph aureus, option B, Streptococcus, option C, Pseudomonas, and option D, Mycobacterium. And the right answer over here is, this is also a direct question, multiple times asked question, and the answer here is Pseudomonas. As I'm getting your reply late, so I'm, yes, right Nyamat, it is Pseudomonas, right. The next question, this is also a direct question. We have discussed much about our otitis externa, about our perichondritis, about our furunculosis, about our MOE, that is malignant otitis externa, which is important in our external ear. So the next question is, one of the following is a feature of Meniere's disease. Option A, presbyochosis, option B, parachosis, option C, diplochosis, and option D, hyperparachosis. So what is the answer over here? Yes. What is the answer over here? Which is the correct answer for the Meniere's disease and the feature presenting in Meniere's disease? Yes. I'm expecting your answers. And the answer here is, yes, that is diplochosis, right? What does it mean by diplochosis? What does it mean by diplochosis? It means double voice. Yes, very right Nyamat and very right Enak, that is diplochosis, and the meaning of diplochosis is double kind of a voice, a double hearing they will be hearing. Okay, so that does it mean by diplochosis, and there are many features in our Meniere's disease that shows very important thing, repeatedly asked things. So saying about the Meniere's disease, what is the main definition of Meniere's disease? The quantity of endolymph or the secretion of, yes, right, Bright, your name is Bright, so I'm saying it as Bright, right answer, Bright. So the quantity of endolymph is increased. The secretion of endolymph is also increased, which means too much of fluid content over there. So because of this, we are calling this as endolymphatic hydrops. Another name of this is endolymphatic hydrops. So the very important feature or the clues which I can give you, if suppose this question have been asked in a clinical manner, so how can you find it? So the first clue is they will be giving you in a middle age, either about 45 to 55 or 35 to 55. Regarding this, the age will be. The second clue which I can give you is this is a kind of a dominant disease. And the third clue which I can give you is it will be unilateral. So this is the clues in clinical case. If suppose they are giving, you can able to find. So some other features as such, this is a abnormality of your inner ear. You have some important features which you have to know about in view of symptoms. So what are all the symptoms within them? You have tinnitus. So you can also say any other important symptoms which you know, that is very important. You can say yes, tinnitus is there. And apart from that, you have SNHL. What is SNHL? Sensory neural hearing loss is there. You will have vertigo and you will have nystagmus also. But what is the difference of this vertigo and nystagmus? They are not a normal vertigo and nystagmus. They are a peripheral vertigo and nystagmus. That's why we have nausea sensation and vomiting sensation as a features. So this is an inner ear disease. Please remember there will be sensory neural hearing loss, vertigo and nystagmus. Another important thing which you have to remember in view of Meniere's disease is their signs. So what is the important signs? The 4 signs that are important is, the first sign is Henny-Bird sign. The first sign is Henny-Bird sign, where there will be false positive fistula will be there. False positive fistula sign is there. You can call it as like this also. What is the second sign? Yes, Ada, correct. Any other reasons causes this Meniere's disease, especially the inner ear disease, you can able to see this bulging, where you will have the 4 signs. Where you will have the 4 signs. So the next question is, which is not found on the medial wall of middle ear? Which is not found on the medial wall of the middle ear. Very important. Yeah, I'm getting like it's still loading. Because of some technical issues, it's loading, I hope so. Medial wall, our promontory is present. What is the importance of promontory? Yes, the importance of promontory is they are supposed to have a present in the base of cochlea. They are present in the base of cochlea. And what's the importance of round window and oval window? So round window also having some unique feature, and our oval window is also having some unique feature. So if you see in round window, there is a secondary tympanic membrane. So here the answer would be a round window. Round window. So in oval window, what is the importance? The foot plate of stapes are present in oval window. The foot plate of stapes are present in, yes, oval window. So that is how they are very, very important. So please remember, foot plate of stapes are present in your oval window, and the secondary tympanic membrane are having importance of round window. So in view of medial wall and posterior wall, in view of medial wall and posterior wall, what are all the things you have to remember, and what is the important thing? Many things are there in your medial and posterior wall, but still, what is the very important thing to understand in view of them? That is, your medial wall will be having 2 bulges. One is your promontory, which we have seen and which we have discussed, right? And the second one is your bulge of a lateral semicircular canal. Bulge of a lateral semicircular canal. And the next thing is, they have 2 windows, about oval window and about a round window we have seen. And one more thing which you have to remember, that is your fistula antifeneastrum. Fistula antifeneastrum is present in your, yes, medial wall, and this fistula antifeneastrum is present anterior to oval window. That is also important point to be remembering. So, and one more thing about the same is facial nerve is present. Facial nerve is present, and in view of facial nerve, what you have to know, that is present in a kind of horizontal nature. Horizontal nature. But this facial nerve, when they are coming to your posterior wall, the same will be in vertical nature. That is important between both. Facial nerve will be vertical in nature. That is how they feel. That is how they are important. So apart from that, what are the important point in view of posterior wall? In posterior wall, you have to remember pyramid. Yes, in pyramid, the important thing is they have origination of which muscle? In pyramid, there is origination of this which muscle? That is a stapedius muscle. That is a stapedius muscle. In that stapedius muscle, why we are speaking very important in view of them? Because the function of stapedius muscle is causing a stapedial reflex, in which they dampens the loud sound. In which they dampens the loud sound, and they maintain and modifies the sound which is coming over in the high pitch to the normal pitch. That is done by your stapedius muscle, which is present in pyramid. Dampens the loud sound. That is how they play a important role. So this is what important in view of medial wall, and in posterior wall you have to remember. So the next question, which is a kind of a clinical case question, right? A 22-year-old male gives history of right-sided ear discharge, foul smelling, and occasionally blood stained. Occasionally blood stained for last 6 years. He also complains of hearing loss for last 2 years. For last 3 days, patient has developed fever with chills, headache, and pallor. Along with that, they are having edema over mastoid region. The most probable diagnosis is, yes, very important to remember. Just whenever you're reading clinical questions, it's just a clue. Don't get panic when you're reading clinical questions. It's very easy to solve clinical questions comparatively when you solve a one-liner question. In one-liner question, what is the thing? If you know the answer, yes. If you don't know the answer, no, it would be wrong. So you can easily, you can guess the answer. But in clinical question, what the thing is, if you know the whole concept, you can able to correlate with the concept. Means, see, in what happens in that way? See, right-sided ear discharge, so that some discharges are there which is foul in smell. So foul smelling is a unique feature of CSOM, chronic suppurative otitis media, right? So you have to see whether it is a safe CSOM or unsafe CSOM. So by that way, if you read the question, you can find it that for last 3 days, patient is having fever. The patient is having fever, edema in the mastoid region. So what is the most probable answer for this? Option A, B, C or D. Means atticoantral CSOM, that is fine. These are unsafe CSOM, but what will be along with that will be the problem which is causing other symptoms. Either it might be meningitis or brain abscess or lateral sinus thrombosis. Along with that, subdural empyema will be there. And the answer over here is yes. I hope you people would be right here. That is atticoantral CSOM along with a lateral sinus thrombosis mastoid region that causes the pain near the mastoid region. So in view of lateral sinus thrombosis, what you have to remember, the signs are very, very important. The first sign, that is Taube-Ayer sign. And what is the next sign to remember? Greisinger's sign. And the next sign to remember, that is your Krobach sign, and the next is your delta sign. These 4 signs are very, very important. So how they play a main role? See, when you compress the internal jugular vein, the thrombused vein which is going in the sinus, that causes pressure. This pressure is nothing but showing your Taube-Ayer sign. Okay, so there is also one more thing. This pressure in the internal jugular vein, if you do it in the normal side, so the Taube-Ayer test will be done whenever there is a problem in your, whenever there is a problem, if you do it in the affected side. Krobach sign would be done in the normal side. That is how they are important. And then if you see, Krobach's test will be there, and then there is a clue of delta sign. That is how they also play a main role within them. So the next question is, the picture suggestive of the condition that is caused by Aspergillus, that is Niger. I know that the options are wrong here. This option is otomycosis. So now you can able to answer this question obviously. So what's the right answer? As the point of bacterial organism over here, that is Aspergillus fungus niger, then our answer should be otomycosis. Please be very thorough about this picture that is shown, in which you can able to see the blackish deposition over here, which is caused by Aspergillus niger. In the otoscopic examination, if you see, you can able to find them very, very clearly. Right? Can you able to find any other unique feature over here? Feature over here that shows in view of otomycosis? Yes. And your total tympanic membrane will also look blackish. Yes. So next question is, it is also a direct question which we have discussed already. That is a pearly white mass behind the intact tympanic membrane. Option A, congenital cholesteatoma. Option B, otomycosis. Option C, otosclerosis and exostosis. Here easily you can rule out the answer. In otosclerosis, we have seen some points and signs. In otomycosis, we know that there will be black in nature. In congenital cholesteatoma only, we have read there is a pearly white appearance. By that case, you can get to know the answer. Option A is right, that is congenital cholesteatoma. About this congenital cholesteatoma which we have discussed earlier. The next thing is the most common complication of CSOM is. So what is the most common complication of CSOM? This is nothing but your, yes, option A, meningitis, option B, that is mastoditis, option C, facial palsy, and option D, labyrinthitis, and option D, labyrinthitis. Then what would be the most correct answer over here? Yes, I'm expecting your answer. Yes, anyone else? The most common, if you know the causes of the any exact abnormality present over in the option, you can easily say. Yes, and the option answer over here is your facial palsy. This is your right answer. So in view of this, about facial palsy, if you wanted to know, if you wanted to know about CSOM and facial palsy, in CSOM, what is the important thing you have to know? See, in CSOM, you have to know two things, right? One is your normal safe CSOM, right? And another one is your unsafe CSOM. Unsafe CSOM, that is the tubotympanic, and the another one is your atticoantral. So what is the important in both? This is nothing but your safe CSOM, and atticoantral is nothing but your unsafe CSOM. Unsafe, yes, right, and safe CSOM. So in safe CSOM, the discharge will be more. Even the discharge is more, it won't smell that much. There will be no smell. Please remember, even if the discharge is more, there is not any smell. And the polyp is a kind of pale polyp. The polyp is a kind of pale polyp. And if you see in atticoantral, unsafe CSOM, the discharge will be less. But they will be foul in smell. That will be foul smelling. And one more thing you have to remember is the polyp is red in nature. Red polyp will be there. So very important. And one more important feature over here is they have perforation in the central. So central perforation. Here there will be marginal or peripheral perforations. Marginal or peripheral perforations will be there. Very important. So how did the treatment they would differ? Here we can do myringoplasty. And in view of atticoantral, we have to do MRM, modified radical mastoidectomy. So by that way the treatment also get differ. So this is how CSOM is very important. They can ask any feature in your clinical correlation by the otoscopic examination, and they can ask you the answer. So the next thing which I wanted you to explain is about mastoditis. In view of mastoditis, what you have to know? There are two things. One is your acute mastoditis and one is your coalescent mastoditis. So can you able to see the outpoached appearance? This only we are saying ironed out mastoid. So in this ironed out mastoid kind of a view, what you can say, the pathogens are very important. They are group A beta hemolytic streptococcus. So, and you can say the streptococcus pyogenes are involved. In clinical presentation, there will be ear pain, right? Obviously, there will be discharge. Along with that, they have hearing loss. That is how they are important. The findings, if you see, there are ironed out mastoid, the first finding which you have to remember ever, and the next sign, that is your lighthouse sign, and the next sign, that is your reservoir sign. So can you able to see this reservoir sign? The presence of the liquid over here which causes inflammation further because of the causative organism Streptococcus pyogenes. So these are all important. Please remember, in mastoditis you have to remember LIR, that is your mnemonic over here. It shows lighthouse sign, ironed out mastoid, and reservoir sign. The next thing about the question is, Bell's palsy have no improvement after 3 weeks. What to do for the management? So in Bell's palsy, facial nerve decompression you can do, continue with the same dose of steroids or increase the dose of steroids, or you can do further examination. What you can do over here? You can do facial nerve decompression also, but after 3 weeks. We can wait till 3 to 4 weeks. We can wait till 3 to 4 weeks. So no issues if you wait for 3 to 4 weeks and if you're being giving the treatment for the patient. So what happens over there? After 3 to 4 weeks also, if there is no any improvement in the Bell's palsy or the facial palsy, then you can have to examine again. So further examination is very important. Further examination is very important with them. And because of this, sometimes you can able to increase the dose and you can go with facial nerve decompression also, but most probably there would be a possibility of further examination, as such that there is only 3 weeks. We can wait it till 3 to 4 weeks. So what we can do, this is a facial nerve palsy where there is no wrinkle of brow will be there. If you ask to do the patient like this, to extend the eyebrows, you will not see any wrinkles, right? So after that, there will be a drooping of eyelids, inability to close eyes, there is a ptosis kind of a view, and drooping of the lower dry mouth in the corner. So this is what happens in your facial nerve palsy, which is a Bell's palsy. The main unique feature we have to know is, in this you have infections like TB and CSOM. So this is the CSOM which we have seen in the last before question. The most common complication of CSOM is facial palsy. Okay, so the next unique feature is they can be because of steroids, use of steroids, or they can be use of metabolic disorder. So this steroids will be given as a treatment. Treatment is steroids. They can be metabolic disorder, that is also a possible reason for them, right? So this steroids can be a possible treatment for them, in which along with physiotherapy we have to give. We have to give along with physiotherapy disorder, where we have to do nerve stimulation. Very important, right? So if nerve stimulation is also not working, then what you have to do? Then you have to do surgical decompression of the facial nerve. So it's just 3 weeks. So that is why our answer is further examination. So next question is, most common hearing loss in children. This is the question which we have discussed already. I hope you know the answer over here. That is glue ear. Most common cause of hearing loss in children, that is glue ear or serous otitis media, or the otitis media with effusion. Next question is, the treatment of choice in case of otosclerosis which is having a positive squat sign. So what would be the answer over here? Yes, stapedectomy, fenestration and hearing aids along with sodium fluoride. So what will be the answer over here? The answer is sodium fluoride. Very important. So how, in view of otosclerosis, what you have to know? The most common site in otosclerosis, very important question, that is fistula antifeneastrum. There is a 2 stages. One is your active stage and along with your passive stages there. In the active stage, there are spongiosis in nature. Yes, right answer, Snehashish. So in passive, they are in the means of sclerosis in nature. Sclerotic in nature. There are many features. It's very nice that is shown in an audiogram of, whenever we are doing an investigation, an audiogram in which you have bone conduction. That is why bone conduction is more showing conductive hearing loss, which is having a sudden dip in there 200 Hz. Very important. So investigation, how can you do? You can do in tympanometry. In tympanometry, what you will get, which kind of a curve you will get, as we all know, that is AS curve. And the treatment is depending upon, the first treatment that you have to give is NAF, which you have said rightly, that is sodium fluoride. And the second kind of treatment which you can go is stapedectomy. Or else you can go by the way of stapedotomy. Stepidotomy, very important. Okay, so apart from this, when you have to do this stepidectomy or stepidotomy, in the sense, the one indication whenever there is sclerosis, not spongiosis, that too in your passive stage, you can do, that is important. So then what we can do during this stepidectomy or stepidotomy, what is the important feature we have to remember? That Cahard's notch will be disappearing in audiogram. Cahard's notch disappears. These are all the very important thing which you have to know in view of otosclerosis. The next question is, this also we have discussed already, foul smelling discharge with a red polyp along with the peripheral perforation. Very simple, lateral sinus thrombophlebitis, attico-antral CSOM, mastoditis and perichondritis, and the option correct answer over here is attico-antral CSOM, because they will be having a foul smelling as we have discussed already, and they will be having less discharge, and they will be having, yes, marginal perforations. So what is the treatment over here? Treatment is modified radical mastoidectomy. Very important. Next, so here are some of the pictures which is showing means of in which view. Anyone else? Yes. So in benign positional paroxysmal positional vertigo, the important thing which you have to know is which semicircular canal is involved. Posterior semicircular canal is involved. Posterior semicircular canal is involved. That is important. So then if you see the presentation, the less than 20 seconds of vertigo the patient will be complaining of whenever they move the neck position, or else if they turn within each other. So this is the maneuver, Epley's maneuver, which is a therapeutic treatment for this kind of a disorder. And this is a Dix-Hallpike test for DPPV, which we used as an investigation technique. So this is what you have to see. And to check our semicircular canal, we are using this test. To check our semicircular canal, we are using this kind of a test. So please remember, benign paroxysmal positional vertigo is very important. So the next question is Grady-Negos syndrome. Grady-Negos syndrome is including all except. So what is important? Yes, conductive hearing loss, option A. Option B, that is unilateral discharging ear. Option C, that is diplopia. And option D, that is retroorbital pain. How it is important and what is the difference within them? Yes. So here the answer is, 19th question, the answer is conductive hearing loss. Why? Because in Grady-Negos syndrome, please remember 3 Ds. 1 D, that is showing your discharge of ear. The next D is deep orbital pain. Means the next thing, that is your diplopia. Deep orbital, or you can remember retroorbital. Diplopia. So why there is a diplopia? Diplopia is because of your 6th muscle. Which is the muscle that is innervated by 6th muscle? Yes, the 6th muscle that is innervated by. I am expecting an answer from you. Even if there is a delay in the network issue, I hope you have to answer the question which muscle is innervated by the 6th nerve. And diplopia is because of that. And deep pain. Pain is because of your involvement of which nerve? 5th nerve, that is your trigeminal nerve. So that is how they are important. Discharge will be there, diplopia will be there, retroorbital pain will be there, and the exception is conductive hearing loss. So these are all an important Grady-Negos syndrome which you have to remember. So this syndrome is because of which abnormality? That is petrositis. Important. In which 5th and 6th nerve is involved. And investigation will be MRI, and the treatment you have to give the symptomatic treatment. MRI, you have to do symptomatic treatment. Yes, LR, very right, V Rathod, lateral rectus. Yes, symptomatic treatment. So this is how they are important. Okay. Yes, the next thing is a female patient with complaint of pulsatile tinnitus. Pulsatile tinnitus with bleeding polypoidal red mass. With bleeding polypoidal red mass in external auditory canal. In external auditory canal. So the most probable diagnoses are option A, glomus jugulare, option B, acoustic neuroma, option C, Maynard's disease, and option D, tympanosclerosis. What is the correct answer over here? Yes, there is a pulsatile tinnitus. Simple clue and a single clue. Literally you can find the answer from this, and the answer is glomus jugulare, or else you can see there is a glomus tumor, or else that is glomus tumor. So in seeing about the detailed view of glomus tumor, what you have to know, most common tumor in the middle ear. Yes, it is the most common tumor in the middle ear, and there are means much will also be there. So what are all the signs? What are all the signs which you have to know? That is rising sign. There is a brown sign. And there is a Philip sign. And there is a Aquino sign. So these are all the signs which you have to know in view of glomus tumor. And the most common investigation, same as like, that is CECT, investigation of choice is DSA. What is DSA? That is digital subtraction angioscan. In histopathological examination of this tumor, whatever the tumor, you have to do histopathological examination. In that you can find the paraganglional cells. That is nothing but your Zellballen cells. That is important. How do you treat the patient? You have to embolize the tumor. You have to do embolization either by view of laser or by the view of bipolar cauterization. As such, this is the tumor you have to undergo along with the radiotherapy and chemotherapy. That is how they play a main role in glomus tumor. Important. So next question is, all of the following are seen in lateral sinus thrombophlebitis except this. We have seen already: Tobier sign, Graziner's sign, delta sign, and the lighthouse sign. So these three signs only we will be able to see in our thrombophlebitis, and we will not able to see this lighthouse sign. As such, with this we will be seeing in, yes, anyone else? This will be seen in which kind of disorder, or you can say in which kind of abnormality? Your lighthouse sign is seen where you will see reservoir sign, where you will see ironed out mastoid also. Yes, that is in your mastoiditis. Yes. The next thing is, while syringing for the ear wax, the cold water should not be used. What is the appropriate reason for this? It may lead to the perforation of tympanic membrane. It may lead to vertigo. It may lead to infection of external auditory canal, or it may make the wax hot. What will be the reason? The cold water, always remember, the cold water always causes, yes, and the answer is it may lead to vertigo. Okay, so this is because of your stimulation of, yes, lateral semicircular canal. Very simple. The next question is, I hope you know this question. This is implanted through. What is this and where it is implanted? Any idea? Yes, this is a cochlear implant. And this is implanted through, yes, that is by a round window. And especially round window into the which scala? That is your scala tympana. That is very important, where they are placed, into which they are placed, and how they are placed. It is a kind of a stimulator where we use it as a hearing aid. Very important. The next question is, Rene's test is positive in. So speaking about Rene's test, wax occlusion of canal, CSOMs, chronic suppurative otitis media, otosclerosis, presbyacusis is also there. So what would be the reason over here? Yes, right. And here in AS, Rene's test, in the sense, whenever AC is more than, means air conduction is more than bone conduction, that will be positive. When in most of the condition they are negative, when bone conduction is more than air conduction. Air conduction always denotes the neural hearing loss. And bone conduction always remembers the conductive hearing loss. So if you see, yes, in otosclerosis also there will be a main feature, AS is there, but about Rennie's test we haven't discussed anything. In CSOM also we haven't discussed anything. So the most probable answer here would be presbyocusis. It's a kind of a age related neural hearing loss. So the answer here is Rennie's test will be positive. I hope you people should be very thorough in your renal tests, where it will be positive and where it will be negative. So please remember, whenever AC is more than BC, that will be positive. In many of the conditions they will be negative. The next thing is a diabetic patient. The last final question, a diabetic patient with a complaint of severe pain in the ear, in which the examination shows the granulations in external auditory canal. Very simple question and very simple answer. Option A, malignant otitis externa. Option B, otosclerosis. Option C, carcinoma and exosteatosis. What is the right answer over here? The answer here is malignant otitis externa. Very simple. So these are all the repeated questions I have given you. It is not a very difficult question to remember. It is also a very, very easy question. We have discussed much about malignant otitis externa. Right. So the next thing is regarding the surgical interventions, I have to say you something else. Where we are going to do meningotomy with grommet insertion. Yes, right answer, malignant otitis externa, Sarika and Adak, you're right. So where we are going to do meningotomy with grommet insertion, any idea? Yes, I wanted you people to answer for this. At any cost, if suppose they wanted to ask in here, they can ask this question apart from image based questions. So in view of meningotomy with grommet insertion, we are going to do this in ASOM, or we can do it in glue ear. Why? Because of the adenoidectomy we are doing, and then we have to give a ventilation tube just because there is too much of collections over there in your glue ear we can do. In meningeoplasty, where we can do meningeoplasty? Yes, in your safe CSOM we can do. Yes, and we can do in view of whenever there is a central perforation, we have to clear the perforations. We can do. Ossiculoplasty we can do in your ossicular damage. Yes, very right, glue ear. In tympanoplasty, when we can do tympanoplasty, very important, we can do in your CSOM, especially you can do in your safe CSOM, same like your meningeoplasty, not any much difference. Mastodectomy means you can answer me modified radical mastodectomy also. As you know, one of the important atticoantal mastodectomy, we can do atticoantal CSOM, we do mastodectomy. Where we will do only meningotomy. Only meningotomy sometimes we can do in ASOM also. Where does this meningotomy is done? Posterior inferior part.